So put in the monitor, everything's fine. I basically turn my back for we kind of talk, the strip looks good after that. I turn my back to start to walk out of the room, and the nurse goes, Dr. Ghodsi. And it was in this voice that was so, when there's a voice that says, something's wrong. Mm-hmm. And I turn around, and the heartbeat has just completely crashed.
The baby's
heartbeat has completely crashed.
Oh, wow.
So low, out of nowhere. So we get her back, I think it was so fast.
And so what that means, the heart rate goes down for the baby. That means what about the baby?
The baby is now in a dire situation and
baby's
could
not
die.
getting enough oxygen.
The baby's heart is not beating,
Oh,
essentially.
wow.
Baby's heart is not beating. So we get her back to the OR. We get that baby out, within 15 minutes max. I think it was
Pretty
11
fast.
minutes. It was very fast. Everything in that process went extremely smoothly, but when the baby came out, the baby's heartbeat was still not there. And they had to, basically do chest compressions.
Oh, wow.
And we weren't sure if the baby was going to make it.
Yeah.
And I just remember, sitting there as a physician, and I'm not even a religious person, and I started praying internally as I'm still continuing to do the C-section, sewing up mom and all of that. And it was a moment where I was like, oh my gosh, this baby may not survive, and I don't know if I would be able to survive after it.
I'm Dr. Larry Burchett. I'm a practicing ER doctor, and as you know, both in and out of the hospital, life can change in a moment. Our guest today is Dr. Pari Ghodsi. Tell us what you do.
So I am an OBGYN, obstetrician gynecologist, and I work for a hospital, and I mainly deliver a lot of babies and see women with gynecologic problems.
Deliver a lot of babies and see women in the hospital.
Yes.
Very happy to have you.
Thanks for having me.
I'm curious about your moment. This is something that impacted you.
Definitely, yeah.
A lot as a doctor.
Definitely impacted me a lot as a doctor, and I think, impacted this patient as well in her life. I can't imagine that it didn't. And so, as an OBGYN, we are often dealing with really, life-threatening situations at times. We have the grave responsibility of not taking care of just one patient, but two. We have both the mom and then the unborn child. And, there's a phrase that I learned in residency early on, which is OBGYN most of the time is great. Most of the time everything's really good, but when it's bad, it's really bad. Yeah. And so that's just something that, has affected me kind of going through the process of training, and then also being a physician, always keeping that in mind. And I think anyone who's been on a labor and delivery floor knows that, nurses included, anesthesia and staff. And I think it's something that's important to touch on in today's world, because we'll get to this, but a lot of people are moving away from hospitals and having home births. And I unfortunately have these sorts of stories that I'm going to tell you, which is a reason why I don't think it's always safe to do so.
To deliver at home.
Exactly. But just to kind of start out with this story.
Let me pause before we get to the story in the moment.
Yes.
You mentioned a little bit, I want to get into what it's like to be an OBGYN and to have this responsibility of delivering a baby. Like, you said most of the time it's great, it's good. Tell me a little bit about that.
So the great part about it, delivering healthy babies and happy families. I remember, there's a lot of reasons why I went into my specialty, but one of the things I really liked was that, people don't always like to go to the doctor, as you know.
They never want to come.
But your OB, people actually like coming to see their OB. They talk to them about their baby. They're typically excited about their pregnancy, and I think it's one of the times that people are really motivated. You'll see a woman that's been smoking for 20 years and has had trouble quitting or hasn't wanted to quit, and then the minute she gets pregnant, she's really motivated. So that's an exciting part too, is that it's not just a time to take care of someone for their pregnancy, but it's also a great time to start healthy habits that can continue post-pregnancy. And so that's really cool too.
It just made me, when you said that, I thought those are moments.
For sure.
When someone becomes pregnant and they want to take care of themselves so that they can take care of their unborn child, that's a moment.
For sure. It's a huge moment. Exactly. And it's also a huge moment when you think about the fact that 50% of pregnancies are unplanned. So, there's the 50% that have been waiting for this moment to get pregnant. Then there's the 50% that are surprised/shocked about this moment.
Yeah.
And it's really humbling to be a part of the time that a woman discovers that she's pregnant, no matter which way she feels about that, and then also to be there during the process and when someone has their child.
Yeah. So to be the doctor, to be the OB, and to give birth, and here it is, here's this baby, and it goes right to the mother's chest and starts breastfeeding. Tell me a little bit about some of the joys of being an OB.
I mean, that's one of them. Like I said, it's such a humbling experience to be a part of the birthing process, to be there. I almost feel like a lot of times you're such an integral part, but at the same time when that happens, you're almost an observer, right? Yeah. And that's such a beautiful thing. I still get teary-eyed sometimes just to witness.
Do you?
Yeah, still. Just depending on the family and the scenario or the situation. It's special. You are there when life starts for the baby and when a different life starts for the family.
It's so crazy. I mean, that's a moment too. I don't know if you knew this. I delivered over 300 babies and did 50 C-sections in residency.
Okay.
And it's just so cool to be a part of that.
Right, it is.
And childbirth is crazy.
It is.
It's so just, and here it is, and then things really start from there for this family, and it's intense.
Yeah,
it's really cool.
It's really
It is really cool. So, but you're the doctor. Like, you have a job to try to do everything you can to make sure that's good. I remember one of my teaching OBs was like, your job is to intervene. Like, when you see things that are happening, you're worried about them, like, that's your job. Like, that burden is on your shoulders. Tell me a little bit about that. Like, how is it to be the doctor with that responsibility? And then what are some of the scary things? Like, I'm really curious, like, do you have a greatest fear as a doctor in delivery? Yeah, I want to hear about that.
So it is still, I don't want to say that every single time it's stressful, because it's not, but it's still not something that I take for granted, if that makes sense. I still try to go into every delivery thinking about the fact of what could be the worst possible scenario in this scenario, depending on the patient's, risk factors or what the situation is.
So you're prepared, and
so that you're prepared. Exactly.
Yeah,
I think when in medicine in general, and I think you can attest to this, you want to be confident, but you also don't want to be, I guess, I don't know what the right word is, arrogant, I guess, towards taking care of the patient, because there are situations that everything seems to be going right and something goes wrong, and you need to be prepared. And we're only human, we can only do our best. But that's why you really need to make sure that you're prepared, and you're kind of going in with the thought process of taking everything into account, and just not being laissez-faire about any of the situations.
Yeah. Or too biased, or blowing something off that's important, but like actually looking at what's going on. Yeah, for sure.
So one of the stories that I was going to tell you about is a situation that I'll kind of start from the beginning of it, and this was definitely a prominent moment in me during my career, and in life. I think kind of is a testament to what we're talking about, that things can kind of switch on a dime. But I had a patient, maybe about, I want to say 5 years ago, and it was this perfect culmination of things that I don't exactly know how to put it into words, but I'll just tell the story and then you can kind of see where I'm going with it. But basically, she was referred to me by a friend. She was referred to me by my best friend from medical school's husband. She herself was a nurse. Her husband was a doctor. And they had gone to several physicians, and I think weren't happy with them during prenatal care. So my best friend's husband said, you have to go see our friend, she's great. So that's kind of the setup of, like, not that every patient's not important, of course every patient's important.
This is higher stakes.
But this is a higher kind of stake situation, right? So
I'm already nervous for you.
Right, that's the kind of thing, you're like, all these kind of added pressures, I guess would be the word, added pressures.
What kind of nurse and doctor were they?
He was orthopedic surgeon, and I can't remember what floor she was on, I can't remember. So anyway, they come to see me. Overall, she has no risk factors. It's her first pregnancy, is a healthy woman, doesn't have any medical issues. The pregnancy goes great. They're very satisfied with the fact that they transferred to me. She comes into labor spontaneously. Everything's going fine. I let everybody on the floor know that, they're, friends of mine, and, she's a nurse, and everything's going just fine. She had a little bit of a delay of dilation, and so I went to put in a monitor, which is called an IUPC. Okay. Which is basically a intrauterine pressure catheter. It's just basically a monitor that goes in to measure the strength of the contraction she's having. But other than that, everything was normal. And that's actually not that out of the ordinary for someone who's laboring. It's just when things kind of start to slow down, we might add a little bit of Pitocin or put in a monitor like this to kind of, give her the best chance for vaginal delivery that she can get.
So sometimes, even in a normal delivery,
yes,
the cervix isn't opening as fast as normal.
Exactly.
So you might do some other things to speed it along because
Right.
you want to get the delivery, including put in a monitor, give some
Right.
extra medicine to
Right.
help with contractions.
Exactly. To just kind of,
keep things moving.
Keep things moving.
Okay.
And really it's also kind of like a test to make sure that she doesn't need a C-section.
Okay.
Because
if she doesn't
if
do
she
it,
if she
would need a
doesn't, then she does,
C-section.
but we need to give her all the benefits, like give her the extra medicine, put in the monitor to make sure that her contractions are adequate. And then once we know all of that, if she doesn't make it past that, then she would need a C-section.
Now, at this point, is that a red flag if things
No, that's
slow
what I'm
down like
saying.
this? Like, that's not necessarily bad.
It's not bad. Most, it's mainly just kind of, like I said, taking the precautions to make sure that, everything's going smoothly. It's a red flag that she won't have a vaginal delivery if we do all these things and hours go by and she hasn't dilated.
And it's still not
Then
helping.
Exactly.
I mean, you can see where I'm like,
Of course.
This is
Of
like
course.
Monday morning quarterback,
Yeah,
where I'm
yeah,
looking
yeah.
at this and I'm like, because I'm worried about what this moment is
Right.
going to be, and so I'm like looking at every little thing, almost like the malpractice.
Exactly. Which
like,
I myself did.
Did we miss anything?
And we'll talk
Could
about
this have
that
been prevented?
afterward, because we definitely, myself included, went through that whole process. Her husband, he went through the whole process. But other than that, again, which happens in a majority of pregnancies, they need a little bump and a little monitor.
Yeah.
So put in the monitor, everything's fine. I basically turn my back for we kind of talk, the strip looks good after that. I turn my back to start to walk out of the room, and the nurse goes, "Dr. Ghodsi," and it was like in this voice that was so, when there's like a voice that says, something's wrong. Mm-hmm. And I turn around, and the heartbeat has just completely crashed.
The baby's
heartbeat has
just gone
completely
down.
crashed.
Oh, wow.
So low, out of nowhere. We, at the time I was at an amazing hospital. Everybody was fast acting on this type of situation. We get her back to the, operating room. We do.
So you have to do a C-section. She's
emergent.
not like pushing and close
and that's
to
what
delivery.
I'm saying. It's a middle of nowhere kind of deal.
Okay.
And so just heartbeat drops.
Kind of out of nowhere.
Out of nowhere.
Wow.
And drops and stays down, basically. So we get her back, I think it was so fast.
And so what that means, the heart rate goes down for the baby. That means what about the baby?
The baby is now in a dire situation and could die. The baby's heart is not beating, essentially. Wow. Baby's heart is not beating. So we get her back to the OR. We get that baby out. I can't remember exactly because it's been years, but within 15 minutes max. I think it was like 11 minutes. It was very fast. In order to roll her back to the OR, get everything situated, and get the baby out. And everything in that process went extremely smoothly, but when the baby came out, the baby's heartbeat was still not there. And they had to, basically do chest compressions. Oh, wow. And we weren't sure if the baby was going to make it. Yeah. And I just remember, sitting there as a physician, and I'm not even a religious person, and I started praying internally as I'm still continuing to do the C-section, sewing up mom and all of that. And it was a moment where I was like, oh my gosh, this baby may not survive, and I don't know if I would be able to survive after it. I just was so, as a doctor, I thought to myself, if this baby doesn't make it, I might have to quit medicine. And I've told people this story over and over, and they're like, no, not really. And I'm like, maybe.
This is what you were in the moment.
This is in the moment thinking. They're like, no. And I'm like, maybe, because yes, we have losses during labor and delivery at times, but there are babies that come in that are very preterm, or the mom comes in off the street already with an abruption, meaning the uterus has come off the wall.
It's too late,
like
and
it's
there's
too
nothing
late.
you could do.
There's yes, but this was a scenario where mom is fine, healthy pregnancy, baby's fine, out of nowhere, and it's on us to save the baby's life.
Okay, so we had a little interruption of the lawn crew outside weed eating, weed whacking, but we're back.
We are back.
I want you to pick up again where, okay, so you just told me everything looked fine. The baby's heart rate goes in the tank. We're worried, like in that moment, we're losing the baby. And like, that's when you're like, this is why I'm here, is to do what I can do to save this baby, which in this case means do a C-section stat, like now, like that, you know. So take me through like what you're feeling and experiencing in that moment. I mean, adrenaline, and you're just like, what is that like to be in that moment as the doctor?
I do think that, like you said, adrenaline takes over, and some of those beginning parts are kind of like route memory, right? Like you don't really think, at least I don't. I've been in other situations, which we could get into or not get into, where, you know, it's time to go and you detach in a way that I think is good. You know, that's why we've gone through so much training, and it's almost like a military-esque mind where you are emotionally detached. You're not really thinking about yourself or your feelings or what the feelings are towards the patient. You kind of just go into military mode, and it's like, let's do these things. And you kind of rush in there, you know, anesthesia kicks in, all the training you have kicks in. When I started in that scenario, started having those feelings, it was once the baby was out. So until that point, it's boom, 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 boom.
I see.
And then now baby's out, baby's getting worked on and things like that. And then the feelings kind of start to come on because, you know, yes, I still have to sew up mom and all that, but the scariest part of it has now
gotten the baby out.
Baby's out. The rest, mom is good, we sew, but that's when kind of the feelings start.
So hang on. So so it sounds like training takes over. So you identify, oh, bam, this needs a C-section now. It's like you push that button in your brain, and you've done that so many times. I mean, like, how many C-sections have you done?
Thousands.
Thousands. So it's like, okay, C-section, you go into that mode where you're like, this incision, and I do that, and then I get the baby out, and then I'm sewing it up, and like, so you're kind of on autopilot a little bit.
That's the right word. I was trying to think about what the wording, the right word.
Training takes over.
Right.
And then, okay, so you get the baby out and you've done your job, that intervention, and then tell me about that. So then kind of the adrenaline goes down out of you a little bit, and then you're like,
and then you kind of can do it, deep breathe. Typically when those type of scenarios where the stat C-sections happen, I usually at that point say, okay, now everyone can slow down, because the whole team is in that autopilot, rush.
Everybody's in adrenaline,
everyone's in
mode.
Yes, exactly. And so then once the baby's out, usually then we can kind of slow down, take our time to kind of readjust everything. Now, at that point, depending on the baby situation, the NICU team is now in their adrenaline rush. Right?
Because now that the baby's out, and they're working on the baby.
Exactly, they're working on the baby.
Yeah.
But for the obstetric team, now we've kind of slowed down, and we're kind of in our last part, you know, not last parts, but the half of the C-section, which is now closing.
Do you remember seeing the baby? Do you have visions of that? Do you remember?
I know, yeah.
Yeah.
I mean, I could tell they were doing chest compressions and CPR.
What do you remember? Like, what did the baby look like?
Blue-ish.
Yeah.
So it was scary, for sure.
Normally, a baby comes out, whether it's a vaginal delivery or a C-section, maybe there's a moment, maybe they're kind of purple ready, but they start crying, they move, they're not blue.
Right. So typically when a baby is a healthy baby, the baby comes out, it's pink, it's crying, it's moving, and these are all things that the pediatrician will take a look at and kind of score the baby on. When the baby's not healthy, or when we're in these kind of crazy scenarios, sometimes even when we're not in crazy scenarios, and that's also surprising when everything's perfect and then the baby comes out looking unhealthy, which is more blue, like floppy color. It's like kind of floppy. It's not breathing the way that it should. So you can get a sense of both of those, and I have seen that, like I said, the babies come out that everything's perfect, and the baby comes out and is just not perfectly, crying and pink and stuff. And a lot of times there's underlying issues with the baby then, and it wasn't really about the labor or the. Yeah. But I've seen both, and definitely when I do see the sad / scary looking babies, you feel bad.
Yeah.
You feel bad.
Feel bad, like just sorry that this
concern
happened,
yeah,
and then like maybe an element of guilt. Could I have done something else?
Right.
And what is this my fault?
Right. Of course. There's concern. Then there's a feeling of like, I hope the baby's okay. And then there's a feeling of, did we miss something? And all of that. So.
I think about this moment of childbirth, and it's such a huge moment, like for everybody. A lot of this is about your experience as a doctor and how this affects you, and
right.
You've carried this with you even years later. There's a baby involved in how this child, are they going to have cerebral palsy?
Right.
Are they going to have permanent brain damage from
right.
not getting oxygen when they were delivered, or like other little things that you and I talked about. Sometimes you have to break a collarbone to get a kid out, or sometimes an arm is. How does it affect the baby? And then the family. Like if there are special needs, like this is
a lifelong. You're responsible for a child, basically. Just because I don't think we ever really said, but just in that case that I did share,
so that specific.
Yeah, the baby's fine. Baby's fine. They, got to resuscitate the baby pretty quickly, and the baby's fine, and everyone's fine. And I definitely did after that do kind of a walkthrough of the labor process mentally, and did I, miss something? Did we miss something? We sent the placenta to the pathologist to see if anything would come back there. Like I told you, the family was a medical family, so they kind of did their own research and talked to their friends. And I mean, it just happened. It was just one of those things that just happened, which brings us to another point that we can talk about as doctors. Sometimes you do all the right things, and something bad still happens. It's not even a matter of did I make a mistake or did I do something wrong.
Yeah, like I'm thinking back on this case, and you told me like healthy pregnancy, healthy mom, labor went fine. Yeah, it slowed down a little bit, but that's common. Right. You did some common things, and then like out of nowhere, all of a sudden the heart rate went down. So it's like, okay, push pause right there. Right. You look at everything before and you scrutinize everything. Like, was there anything? There was like nothing, and then like. From that moment, again, where you hit that button and you went into C-section autopilot, like you did the right things there. Like it doesn't sound like there was anything else you could do. No. And then so then everything turned out fine. Thank God. Right. God. For everybody, including you.
Right. Thank God.
What would have happened? Like, what if everything would have been, you would have done everything right. Mom and dad would have done everything right. You do the C-section as fast as possible. And then what if still there was a bad outcome?
That's awful.
I hesitate to even say this, but there's a truth to it, which is sometimes things are outside our control.
Yes.
Ours as doctors, like people as patients and as family, and that's in this day of technology, and we have a little bit of a fantasy of live forever, we can cure everything. We really can't.
Right. And I think that's something that is important in society to recognize. I think just generally speaking, 50 years ago even, doctors were more revered. They were more respected, and but it was with an understanding of they're not perfect. Where now it's kind of shifted in this weird way where there's an expectation for you to do everything right, to know everything, to not make mistakes, combined with, and if they mess up, it's their fault. I Googled, they should have done this other answer. I talked to this friend of mine, they had this other situation. So it's like a combination of this like great expectation, and therefore you're not you're not meeting all the expectations all the time, and therefore there's less respect. I don't know. It's hard to...
The thing that you're saying is perfectionism. I mean, this is like, you're held to this standard on the one hand, like there should be a high standard in medicine.
Yes,
but on the other hand, I think one of the themes you're bringing up is we are human. Sometimes we do make mistakes.
Right.
Sometimes things are outside our control, but sometimes we do make mistakes.
Right.
And let's take another scenario, which you haven't had. Let's say you did have a bad outcome, a child that has cerebral palsy or
Right.
some kind of permanent mental,
Right.
developmental delay because of the way labor was managed, like, how would that impact you?
Right.
You
Yeah.
know, like, you said something to me a minute ago, I think it's okay to say this, is like, you don't know if you'll do this forever. You know, like
Right.
the fear
Yeah.
of, what if there's
The
a bad
stress.
outcome
Yeah,
and it's my fault?
Right.
You know?
It's like a very hard, I think, weight to carry. I had this talk with my parents one time, and it was kind of funny. Like, I was in the car with my parents, and my dad is an entrepreneur, and he owns his own company. And my mom had she's an accountant, and had started working for his company for a little bit. This wasn't that long ago. And she was like, I just have so much more, respect for your dad on a daily basis, because I just realized what immense stress he's under. And I was like, no one's under more stress than I am. No, you don't understand. Like, he's under so much stress, and he has all these employees. And I was like, okay, but let me break it down like this. And again, it wasn't to toot my own horn. It was just to get even my own family to understand what we as physicians go through.
Yeah.
I was like, let me break it down for you. I was like, what is the worst thing that can happen? Worst thing. His company crashes. He loses a bunch of money, and of course, he genuinely does care about his employees and their families. But so let's say, and 400 people lose their job.
Yeah.
That's bad. What's the worst thing that can happen if on my job?
Yeah.
A mother and a baby die.
Right, both.
That is like a level of stress that I don't think people even can internalize unless they've been in our shoes as physicians.
Yeah.
It's a totally different ballgame. And we're not, we don't show it because it's our job. But when you break it down that way, it's pretty impacting.
It's crazy. There's a reason we can use denial, in a helpful way, and like not thinking about that all the time. It's as you say it, it's impacting me even now. I recently had a patient die in the ER. I was telling you about this earlier, who came in alive and then died on my shift under my care, and I looked at it and figured out why the guy died, and there was nothing that could be done. Nothing. There's nothing that would have stopped this from happening. But still, there's this lingering doubt and guilt and perfectionism of, what if I would have figured it out earlier and done this and done whatever? And the answer is, no, the guy's still going to die, and there was nothing you could do. But there's still that lingering. Part of it is the same. I'm speaking of the same thing you're talking about. It's this perfectionism. It's this standard, and I think that's a big part of, what burns doctors out.
It's a
and
burden.
Takes people
It's a
out
burden.
of
And we don't
this
talk about
job.
it. That's the thing. A lot of times physicians don't talk about it. Because we go through training that's very, similar to a military model, where you go without sleep and you go without food and you keep marching on, and you take kind of this hierarchical, I hate to say it, but abuse at times.
Oh, it's absolutely what it is.
And because of that, you come out stoic, right? And we have to be able to be that way, because we are dealing with situations where there are life and death decisions being made, and you need to be able to be stoic, and you need to be able to separate yourself from it. But the bad side of that is that then we do these types of crazy, life-saving, life-threatening deals, and then we come home to our friends and our family, and we're like, what's for dinner? Like, nobody talks about it.
How was your day, honey? It was fine. How was yours?
We don't talk about it. We don't share feelings surrounding it. We don't say, well, this stressed me out. And no, because there's a certain expectation for us not to do those things. And I think that's a big part of, like you said, physician burnout, is that we're not sharing our feelings towards this grave amount of stress that we walk around with.
It's just, it's not structured and institutionalized. So this patient of mine that died, he died in the middle of my shift. I can't be like, hey guys, I'm gonna go process this for a while. Like, I got to get out of here. I'm kind of messed up in the head.
Exactly.
Like the charge nurse would have said something like, oh, that's fine. Take a minute or two. There's 6 patients waiting for you. Like, the waiting room doesn't go home.
No.
And so it's just like, you have to compartmentalize it. You got to put it over there. You got to take care of people, because you don't know, maybe one of them is going to be the same thing.
Exactly. Yeah.
There just isn't that space. And then later, whatever way you do, whether it's talking to somebody, it's nice to like hear this and talk about this stuff with you, or journaling or whatever the way.
Yeah. Some way of kind of working through it, I think is.
I like to call my old mentors and just run the case by them.
Oh yeah,
and they'll just
that's
tell
good.
me. They'll be like, "Yeah, you missed something,"
Right.
or it's like, "You know what? There was nothing you can do."
Right.
And sometimes that just helps to, let go of it,
Right.
and to keep going on. Like I don't want to hang it up yet.
Right. Yeah.
Like we're not that old.
Yeah.
Totally.
Totally.
That you even mentioned for a second a case like this, like. I don't know if I'm going to do this for forever. Okay, so let me ask you this. So that was the moment. How did that impact you afterwards? Like, were you changed a little bit? Did you think about things differently? Did you practice differently?
I don't think I practiced any differently. I do think that like we have kind of alluded to, it made me just recognize, not that I didn't know already, but kind of recognize what was at stake with my job. I don't want to say that I was naive prior, because I wasn't, and I did understand like how important what the things that I was doing were, but I think it made me realize how much it would impact my life if something were to go wrong. And kind of being able to look at myself in the mirror and think, wow, like, I even jokingly said, I remember to a friend when I was telling the story, maybe I'm not cut out for this.
Yeah.
Because if something, like, knock on all the wood in the world, I haven't had something that was really a bad outcome.
So you've never had a bad. This one was scary and
This
close.
was scary. I've had some bad outcomes, but nothing minor. Nothing that's, a death situation. And I don't know if I could handle it. I don't know if I could keep practicing if that were the case. Maybe I am too sensitive for it. Like, I do remember when we were deciding, specialties very early on, I was like, I could never do oncology. I could never, one of the highlights of OB is most of the time people are alive. Now we have miscarriages and we have fetal losses and things like that we can talk about. But when a healthy, normal, pregnancy, if I were to lose a mom or a baby, it would be very difficult for me. And I think that's when I realized that.
I can think back to residency, and I feel like I even heard this recently. I don't even practice where I did residency before, but especially when there's a maternal death around a delivery, that's the one where everybody is just like, oh man, we screwed. Everybody goes through that process of what happened, what could we have done, and really dealing with the guilt and the loss.
Of course, because they're young, healthy women, and they've come in to have a baby, and then this.
And that shouldn't happen.
Yeah. But it does, and it does happen. It does happen, and I kind of alluded to this when we first started talking, but that's why another I think takeaway point of this story, or how things changed for me, is that I've never believed in home births. So I'm not going to say, oh, I used to and now I don't. I never did. But it reinforced my beliefs that, I am fine with, midwives. I'm fine with those types of deliveries, but I do think they should be in hospitals because, like I said, most of the time things are good, but when they're bad, they're really bad. And if this would have happened at home out of nowhere, these people would have died. And what people don't understand is that maternal mortality, like you're saying, when this happens in a hospital, everyone feels guilty and it's like shocking. It's still a #1 cause of death of women worldwide. This happens all the time.
Oh, that's crazy.
In other places where they don't have access to care. So, there's actually, interestingly, there's been a lot of stuff in the news recently about, maternal mortality in the United States has risen. And part of that is to defend doctors and to defend midwives and labor and delivery nurses and hospitals. Part of the reason that has changed is because the criteria changed. They used to say maternal mortality was up to 6 weeks. And, I think based on I can't remember, CDC or WHO.
6 weeks after delivery.
Yes, that's if people died within that. Now they're saying up to a year. So of course it
So they
increased.
changed the definition.
But they changed the definition.
Some people would say it increased because of obesity.
Right. There's also a lot of heart issues. Yes, obesity,
more comorbidities,
heart
during
disease.
delivery.
Exactly.
Are you suggesting that home deliveries may contribute to the increase in?
No, not necessarily. But what I'm saying is, I don't want people to hear that statistic and run away from a hospital.
Oh, okay.
Because a lot of people will hear that statistic and say, well, see, there's something going on in the hospitals, and I don't want to have my baby in a hospital.
So tell me, it sounds like you feel pretty strongly against delivering at home.
Yes.
Even for a low risk, like healthy pregnancy.
Yes.
So give me your.
Well, yes, I just don't.
Okay, good. Give me.
Yeah.
Let's make that clear. So
Yeah.
just to just for me to come out of the closet. I mean, my daughter's 9. I was not comfortable with that happening at home.
Yeah.
In a million years.
Yeah.
Just because, similar to you, I've seen enough bad
Right,
things.
you see enough bad things.
And it's rare. It's one in a whatever. And
Exactly.
yes, most of the time things are going to be
Right.
fine. But there's 2 people you care about
Yes,
in there. The
yes.
baby and the mom.
Yes.
You know, and like I've seen so much bleeding.
Exactly.
And just like these
So much
complications
bleeding.
that are easily manageable. Okay, that's me talking. But so
Yes.
tell me, so I'm.
You know, I went to a wedding this past weekend, and I was talking to a old friend of mine that was at the wedding, and she was like, yeah, you know, on my first pregnancy, I lost 1,700 cc's of blood. She had postpartum hemorrhage,
Yeah.
which is a lot of blood. I was like, oh my gosh, you're so lucky that you made it and everything. And that kind of thing, if that's
She
at
delivered
home.
at home?
No,
Oh,
in
she
the
didn't.
hospital.
Yeah,
Yeah,
okay.
they transfused her immediately and they did all the maneuvers and gave her medicines and things like that.
Yeah.
But if she was, and we walked through again, I walked through all the stuff with her. Well, did you have this? Did you have this? Did you have this? No, it just happened. It just happens.
So something that you said that made me think about this, you know, when people think of the hospital and then you think of, oh, home birth. When I think about that, it's like I get this sense of, oh, it's a home birth. It's like you're getting a massage and there's these, it smells good and you're in a bathtub and it's warm. It's like you're in a hot tub and there's this feeling that comes along with it. You know, like that's kind of what you've been sold a little bit. When I think about the hospital, like it just is. People think about IVs and you think about, so there's this book called The Culture Code and just to quick summarize it, what people's kind of gut, visceral feeling, subconscious understanding about something is determined by 3 things. The first, or the imprint that it was, so the first time, which most people, the imprint for a hospital was grandpa's dying. So hospitals where people go to die. Number 2, the most impactful thing. What's the most impactful thing that happens at the hospital? People die again. And then 3, the most recent thing, so whatever it is. So people have this unconscious just fear of hospitals and association. The culture code for hospital is death in this country. It's not healing. It's not healthy delivery. And there's a different culture code for delivering at home. But like you, even though those ideas may sound good, there's risk.
Well, there's risk, and what I, tell patients is, you can do all those things. That if you want to put on music in the delivery room, that's fine. If you want to do intermittent monitoring, as long as you're at low risk, that's fine. If you want to dance around with your spouse, that's fine. If you want to, whatever you want to do to make it feel like this feel-good feeling that people are having at home, that's fine. But just be in a situation that if things go bad, you're an appropriate place for people to take care of you. Even on a very minor level, I've seen so many people come in from home deliveries with just awful tears that are bleeding. Vaginal tears that need real repair. I mean, and I just don't understand it, because I feel like there are so many people worldwide, even so many people within our own country that have a limited access to health care. And for people that are privileged and have all of the healthcare access that anyone could ever want, for them to deny that just doesn't make sense to me.
What kind of risk are we talking? One, can you give me any numbers about, so let's pretend we have somebody here who's thinking about it. Like what, and they're like, well, I think I'm going to go at home. Okay, there are bad things that can happen.
Right.
What's the risk? Do you have any numbers?
I mean, we try to say nationally about 1 in 4 pregnancies are going to end up needing a C-section for one reason or another.
Wow, okay. So the C-section option.
Right.
Somebody could labor at home and then get stuck and come in.
And then they have to come in, which does happen.
Yeah.
But, you know, the problem is if you're at home and you get stuck, a lot of times that goes on too long and now they're infected because they've been at home and complications of that. You know, like we talked about, besides just the C-section risk, like postpartum bleeding risk. I don't remember what the percentage is, unfortunately.
Yeah.
But it's there, you know. And then again, there's all the risks too, and I don't know because I don't know what's happening at home. A lot of times people that are doing home births are also doing more risky births.
Yeah.
Like they want to deliver breech vaginally, and we don't typically do that. You know, you'll find less doctors that are willing to do that these days because of the risks.
Yeah.
So they opt out of the hospital because they want to do it at home. That in itself is risky. You see what I'm saying? So it kind of like, it adds on another risk factor because a lot of times they're doing risky things at home.
Yeah, I wish I don't have the numbers
I would
either.
like
I
to
just
look up the
wish I
numbers,
had
and
the
I'm
rate of
sorry,
complication. No, I don't expect you to know that. 1 in whatever, or
Yeah.
ultimately 1 in, 100 would die or something like that. Let me say this. One of my best friend from college, when they gave birth, they were in a center that had 2 sides. And one side was kind of a more natural, they didn't do
Right.
monitors, they didn't do whatever, but she ended up having a complication. And they just rolled her down
Yes.
the hall.
See,
and
and I
so
like
then
that.
she went somewhere, then they
Right.
put in the IV, and she
Right.
had to get Pitocin and all this stuff.
Right.
And it was time,
Right.
you know,
Right.
and she was ultimately able to give birth without a section.
Right.
But I was like, I really liked that there was that option.
Exactly.
And then you just roll down the
Yes.
hall. You can, you know, because I think, you can look in the ER, it's the same way, right? I'm like, okay, here, you know, this is what I think's best. Like, how many times does anybody listen to me on
Right,
that?
yeah.
Like, not very often. People are
Right.
going to live their lives. Okay.
Right.
We'll meet them halfway there.
Yeah.
You know, like, okay,
And
birthing
totally,
center
like
over
I said,
here.
I'm fine if you want if you want to make it as natural as possible for you. I don't have a problem with that. I'm not someone that's like you have to do anything really, but just until the point that now, if you don't do it, it's a risk for you or it's a risk for your baby. So just be in a situation where you have the options.
Yeah. Let me ask you a couple questions that's kind of related to this stuff, because you do see, as an OBGYN, you do see loss, whether it's miscarriage or a stillbirth or middle of the pregnancy, like the baby's gone. Let's talk about miscarriage.
Okay.
Let's say you have a patient who has an early miscarriage, 6 weeks, 7 weeks, 8
Right.
weeks. They were excited. They were going to have their baby. You know, because I see that in the ER a lot.
course,
Incredibly emotional. Like, I've broken that news so many times. Everyone's crying. There's tears, and that's a
Yeah.
hard moment. What do you say? Like, what is your, and the 2 things I want you to talk about was like, what do you say about the loss?
Right.
And then what do you say to the woman, the mom, who often they feel broken, they feel like,
Of course, yeah. It's part of the whole.
yeah,
part
like,
of it.
am I going to be able to have a baby again? And what
Right.
do you say about
So
miscarriage?
in terms of early miscarriage, which you pointed to, which is in the first trimester, which
Yeah.
is less than 13 weeks.
Yeah.
So when we look at miscarriages like that, it's 1 in 4 of pregnancies will end in a miscarriage. We think some of it is even higher. We think it could even
Pretty
be up
common.
to, it's very common. So we think even it could be up to 50%, but a lot of pregnancies are you miscarry even before you
So
know you're
early.
pregnant, right?
Yeah.
So it tells you how common a miscarriage is. So of course, at first, you know, I tell my patients, you know, how sorry I am for them and the loss. And then I just, you know, reinstate that it is something that's common. You know, most women, you know, have either experienced a miscarriage or know someone that's experienced a miscarriage. And this doesn't mean that they're not going to be able to have a healthy pregnancy later.
Yeah, I was going to say, am I going to be able to have a baby?
Right, of course.
Should I get
The only time that
the
only time that we recommend that someone starts to get an infertility workup for, it's not necessarily infertility, but what we call a recurrent miscarriage, that is going to be when you've had 2 or 3 in a row. That's where we start to get concerned. So I always, you know, reiterate to someone, if it's just 1, it's your first one, there's no reason to think that at all. Now, when you start getting into 2, 3 in a row, then it's probably time to seek care and a special care and do a workup to figure things out.
I'm sure you've had countless moments where there have been losses, not only of a miscarriage or even a pregnancy that's farther
Yeah, those are
along.
the hardest. The
Yeah, what do you say
hardest
to a
are,
patient
you know,
who-
it's sad. It's still sad now. I just tell them I'm sorry. I mean, it's a genuine sorry, you know, sadness that happens. When it's the further along a loss is, the harder it is, because also the more rare it becomes. You know, the ones in the first trimester are common. When you start to get into the second trimester, that becomes a little bit more rare, and then third trimester, it's really like less than 1% of pregnancies you will lose that
So
far
uncommon,
along.
yeah.
So uncommon. So those are very difficult and sad.
Yeah, I mean, it makes me like. I was thinking even like, you know, thinking about some of these spiritual things. Oh, live in the moment, the power of now. Don't have any expectations. And I was like, no, like people get pregnant and then you just start thinking of little booties and making making the kids' room and everything. And like when that for a certain pregnancy is gone, like that's just gonna hurt. You know, that is the process of grieving and, you know, all of those stages of acceptance and depression and just kind of moving through all of that.
It's awful.
Thing. I remember in residency, you know, it just stillbirths and even full term, you know, outside of labor when it was not these crash C-sections and that's crazy stuff, but then it was like you do this ultrasound and it's like the baby's heart's not beating anymore and the baby has actually, you know, died in just that incredible loss at that period, you know.
Yeah, it's terrible.
Gosh, this has been good. I'm all like, this was not a light little morning chat.
No, it's good, but yeah, hard stuff, I guess.
Yeah, no, a lot of it is hard and real stuff. You know, most of the moments that I think of with your job, though, are. Oh, you don't like me leaning back in the chair. I feel like most of the moments, though, are joyous ones and they're good ones.
Yes.
What would you tell somebody, a medical student or somebody who's thinking about OBGYN? Would you say, yes, do it? Would you say, no? What would your advice be?
I would say if you feel it's the same way as if I tell people if they're even thinking about medicine. If you feel like that is your passion and you're ready for a hard and long road, then go for it. You know, I remember somebody saying to me, whatever specialty you go into, make sure you're okay waking up at 3 a.m. to do whatever it is that specialty does. And I still feel that way. Like I don't, even though I still like what I do, like I don't love the hours at times or that, you know, we have to be up in the middle of the night. But I don't really see myself doing any other specialty.
You still deliver a lot of babies.
I still deliver babies,
all hours
yeah.
Tell me a little bit. You kind of do an interesting.
Yeah, so I am what's now called an OB/GYN hospitalist. It's modeled similar to like an ER doctor where we do shifts. We work for the hospital. Yeah. And so I'm taking care of a lot of patients that are either undoctored or they kind of go to these outside clinics where the doctors share. They don't always come in for their deliveries because they're tied up doing other stuff. Or, you know, someone who is supposed to deliver in Chicago and she's in town for her brother's birthday and goes into labor, you know, things like that. So we take care of those patients and then ER patients as well that have GYN issues. So I don't have any of my own patients anymore. Like I don't have a private practice or the clinic. I miss the continuity of the patients, of being with them through the 40 weeks, but it also frees me up to do other stuff. I do charity work. I get to do fun YouTubes like this and educate people outside of the office.
Fun YouTubes like this?
Yes.
Nice.
Yeah.
Okay, so I have a question for you. We're coming to the end, and I like to ask these to everybody. Do you have a personal mission? Do you like what is your big why? I love that idea.
I think my big why is to obviously help women with their health, but also to empower them with knowledge about their own bodies so that they can partake in the healthcare process with me.
That's awesome. I like that.
Thanks.
So I think this is a good question, especially as a physician, I'm really curious, how do you practice self-care? How do you care for yourself, and what are the challenges in your own health?
I think we've talked about this before amongst us. I think self-care for me is, I explained a little bit about what I do as a job now, where I'm an OB hospitalist, where I work for the hospital. I used to be in private practice. Part of that transition for me was recognizing that I was working 24/7, and where now I have more of a work-life balance. I do work long hours and I do long shifts, but I also have days that are just for me, whether that be education that I like to do, or doing something like this, having time just to, walk on the beach that I did this morning, just having days that are more for me and not just about practicing medicine.
What are your current challenges?
Challenges, I think, is sleep. It's always a challenge,
Yeah, right.
I still do these weird hours, and then yesterday I had to sleep all day. So I always have this constant feeling that I'm either undersleeping or oversleeping. I don't think I have a good circadian rhythm.
Mine is so destroyed.
I just sleep when I sleep and sleep when I don't. And I think that's a challenge. And as we know, sleep is so important for, processing the day, for living a long time, for, giving you the energy to eat healthy, to work out. It really is a foundation of so much that we do. So that's a challenge for me. Like, I always notice when I'm sleep deprived, well, that's when these weird cravings come on for sugar and carbs and stuff that I don't normally eat. Yeah. So it's really a basis for so much that we do, and it's hard.
I totally agree. Sleep is so important and hard to get.
Yes.
Is there a book that you recommend for people, either that's a good reference where you're like an OB and you're like, here, this is a great book, check it out, or like a book you would recommend even outside of medicine?
OB-wise, I always just give the what to expect when expecting.
So you think that's good?
I think it's good. It's a good reference. I don't think it's a good read-through all the way through. I think it's a good reference point. I think book-wise,
I might actually check it out at your recommendation.
Well, which one? This one?
No.
That one. I don't
expect.
think it's great. I think it's a good reference. But if someone's going to need a reference, it's a decent reference. Yeah. But it's not a read through all the way cover to cover. It's more like, hey, I'm having this symptom in pregnancy. Let me go find out about it, I think. I think life-wise, I would say Brene Brown.
Do you like her?
Daring Greatly, yeah. I think that was a game changer for me when I read it.
Daring Greatly was a big one.
Yeah.
How so?
I think at the time I was getting just more introduced to these ideas of vulnerability and living life with boldness and being yourself, and it was kind of a breakthrough book for me. I read it, I don't know now, it was probably 6-7 years ago, something like that.
I love Brene Brown. My sister turned me on to that.
Yeah, it's great.
But we need a Brene Brown man version of that.
Yeah.
So the language, I think, is sometimes not written for us. It's not. There was one more question I was going to have. We'll finish with this one. What advice would you give a younger self, maybe 10 or 20 years ago?
Whoa, that's tough. I'm going to play devil's advocate and say I don't know if I would necessarily give myself any different advice.
Okay.
Because I think everything that happened so far in my life, good, bad, mistake, not mistake, happened at the time that it should have and has occurred in a way to get me to the point that I am now. So I don't know if I would necessarily give myself any sort of advice. I think I needed to go through whatever I needed to go through at the time.
Fair answer. Good. Thank you very much for being here. This was an incredible interview. I can't wait to share this with everybody.
Yeah. Thank you so much for having me. It's been awesome.
How do I close it? What do I say? I know where to look. Thanks for coming. See you next time. There's got to be some kind of...
If you enjoyed today's episode, or even if you didn't, check out, something like that. Check out our other episodes for more life-changing moments.
Thank you for coming to the show today and watching. Subscribe if you liked this. The show notes will be available on drlarry.com, and we'll make sure to put a link for it there. And there will be another one next week. We'll see you then. Okay, like this is a little bit of an intense question, but I
Okay.
really like it. Do you have a personal mission? Like, do you have a big why?
Okay. Oh, you're doing it.
Yeah. That was a great one.
Sorry, I didn't know we were doing
Oh,
it.
this is all making it in, guys.
I didn't know we were doing it.